So thank you very much for the invitation to come and speak. So I was given quite a broad title, so I hope I do it some kind of justice. So my name is Tom Wilkinson, and as said, I'm from Leicester. So you'll notice at the bottom of each slide there's a little red box. I've tried my best using Google Translate to put it into some German. If it's wrong, then blame Google. So hopefully it'll give you the gist of what's going on, if you can't understand what I'm saying. If anybody would like the slides after, I'm happy to send them to you, so you can go through them a bit slower. So this is the contents of my talk. I'm going to give a bit of an introduction about myself and who we are in Leicester, where Leicester is. Talk a little bit about renal rehab in the UK. I got bits of your talk, so hopefully I'm not going to repeat everything. Why evaluating and assessing renal rehabilitation is important. Talk about some common assessment methods that you probably or may have come across. And then kind of my 6 considerations that you perhaps need when you're interpreting or using different assessments in nephrology. For those who don't know where Leicester is, we are kind of right in the middle pretty much. So London is obviously down here, Birmingham is about here. So we're quite close. It takes about an hour on the train to get to London. This is Leicester here. It's quite a small city in the UK. There's about 350,000 people. Most famous for lots of cheese, Stilton cheese, and our football team used to be quite good, but not anymore. 13th largest city in the UK. And importantly, we're one of the most ethnically diverse cities in the UK, more than Birmingham, more than London. And around about 40% of the population of Leicester are from primarily a South ethnic background. So I work as a physiologist as part of a multidisciplinary team in Leicester. So our team is led by Professor Alice Smith. We are a mix of physiologists, psychologists, behaviour change experts, immunologists, basic scientists. We've got doctors, physios, students, research therapists. So we're quite a large group. And our primary interests are looking at how we can help patients with kidney disease have a healthy lifestyle. And we think this is primarily through physical activity and exercise. But we're also started to get interested in things like symptoms and self-management. We're particularly interested in body composition, so how muscle impacts patients with kidney disease, and obesity, which is a very big problem, physical function and disability, and we try and underpin all the research that we do with more basic mechanistic science. So we have some very good lab scientists in our team. So just a very quick kind of summary of renal rehab in the UK. So unlike cardiac rehab or pulmonary rehab, renal rehabilitation isn't funded by the National Health Service. There are some hospitals that actually do offer an inpatient renal rehab program, so King's College in London, but currently there's nothing else. So as far as I'm aware, Japan is actually the only country in the entire world that offers a state-funded renal rehabilitation program. And in the UK at the minute, there are 2 very large studies that are funded by the NHS that are actually looking at intradialytic exercise. So these are getting patients on dialysis to cycle whilst they're having dialysis. And it looks like if these 2 are positive, which hopefully they will be, then this will be starting to be funded by the NHS in the UK. So kind of more onto the topic of my talk then. So I've been asked to talk about renal rehab assessments. So I thought, well, why are assessments important? Why do we care about the assessments that we do? And I think a lot of it comes back to what is the goal of renal rehabilitation, what are we trying to achieve in rehabilitation. And there are lots of different things we're trying to achieve: to improve quality of life, to improve independence, to improve activities of daily living. But I think a key aspect is to improving people's physical function. And if physical function improves, then that underpins a lot of these different measures. So why are assessments important? Well, one, they allow us to assess current status of a patient's health. They allow us to create goals for the patient. They allow us to evaluate whether the rehabilitation that we're doing is working. And some actually may be able to predict long-term outcomes. And it's really important that the assessments that we choose relate to our overall goal of what we're trying to achieve. So I think this might have probably been discussed briefly, but it's pretty well established that physical function is reduced in CKD, and this steadily declines as we go from earlier stages of CKD through to stage 5 and then dialysis. This was a study from a Japan group, and you can see that all these different measures of physical function steadily reduce as renal function reduces. And physical function, we know, is a fundamental component of health and quality of life, and as I said, underpins a lot of activities of daily living, and also is responsible for patients' participation in social and recreational roles. So, in terms of physical function, there are 3 models in primarily in CKD. This was mentioned briefly. So the International Classification of Functioning model. So there are 3 models. There's the NAGI model, the National Health and Aging Trends model, and the International Classification of Function model. It doesn't really matter what each model is, but what they are, they all include the same 3 components. And that's really important when we're assessing a patient's physical function in CKD. So the first one is physiological impairment. Okay, so all of the models have this in some way or form. So this is the impairment to the body. So what is going wrong with that person's body in terms of a structure. So this could be reductions in muscle size that are causing reductions in muscle strength. It could be reductions in exercise capacity, so fitness. Now, if we have an impairment, then this usually results in some kind of functional limitation. So this is what's happening at a functional level. So this could be reductions in walking speed, reductions in ability to carry heavy loads, for example. So these are the limitations at a function level. And then ultimately, if patients are limited by their function, they have reductions in participation and disability. And this is their ability to carry out activities of daily life. Now, physical function can be measured using primarily two different ways. And I'm going to talk about these in a bit more detail. But the first one is subjectively, so this is self-report measures. So the Barthel index that was mentioned before, that would be a subjective measure. The other way is an objective measure, and these can be split into laboratory and field testing, which I'm going to come back to. So why is this important? So if we look at our models of physical function, so we have our physiological impairment, so what's going wrong with the body. Okay, so for example, I've taken fitness. Okay, so cardiorespiratory fitness. Now, in order to assess that in our patient, this would be a form of laboratory testing. So this would be cardiopulmonary exercise testing. Okay, and this allows us to measure fitness very accurately. And again, I'm going to talk about that a bit later. In terms of a functional limitation, we need an indicator of their fitness. Okay, and this is usually done by more field testing. So these are two objective measures, such as a walking test, so the 6-minute walk test. And lastly, how do we measure participation or disability. So this is the consequence on the patient, their activities of daily living, and these are often done via self-report measures, so subjective measures. So you can see that for each level in the model we need a different method to assess it. And generally as we go through the model, the specificity reduces. Okay. So I'm going to talk about subjective assessments. Okay. So subjective assessments, as I said, are self-reported, but they can be observer-led as well. So this could be the doctor or the physio looking at a patient's function. Now, these are really important because they capture what a patient thinks they're able to do. So it's their perceived function. Now, these are usually quite good because they're very easy to administer, they're quick to complete, and importantly, they give the patient's viewpoint. And I'm going to talk about two for today. This is by no an exclusive list, and potentially ones that I don't advocate, but these are two common ones that you may have come across. So the first one is the 36 short form health survey, which I'm pretty sure all of you probably would have come across or might have seen in studies. It's a very common measure across all research, not just in nephrology. So it's a questionnaire. It's split into 8 domains, okay, which are here. So you can see there's pain, physical function, vitality, and these form 2 components, a physical component and a mental component. It's a validated measure of quality of life and is actually recommended to be used in nephrology, including by the KDOQI guidelines. It's a recommended measure of physical function. And what's quite good about this is because it's so well used, there are normative values available, so we can compare the patients against a healthy person, if you like. And unsurprisingly, so this is a study from the USA. These are the different components of the questionnaire, and you can see these are patients not on dialysis, so non-dialysis CKD patients, and dialysis patients. So their physical function, their self-reported physical function reduces, and you can see both of these are vastly different from the general population. So they decline with renal function, they're worse than the general population, and a lot of these are actually linked to clinical parameters, so mainly hemoglobin. Now in dialysis patients, this questionnaire is actually a very powerful predictor of both mortality and hospitalization. So for every 1 point a patient increases on the physical component score, that's associated with a 2% reduction in mortality and hospitalization. And actually only age and renal function are more closely related to death than that score. So it's a very powerful predictor. And in this study, they actually said that if you have a physical component score of less than 43, then you're at a significant risk of death. So the second questionnaire, if you like, is the Duke Activity Status Index. So this isn't quite as common, okay, but it is fairly used in nephrology. So it's used to assess functional capacity mainly, and it can actually predict somebody's exercise capacity. So it's a questionnaire, it's got 12 items, such as can you climb a flight of stairs, and all the patient's got to do is answer yes and no, and that's it. And then each of these responses is given something called a MET, but this is essentially an energy requirement to do this. And then it gives you a score of 0 to 58, so the higher, the more functionally able. And this has been validated against VO2 peak, so you can actually predict somebody's exercise capacity using it in CKD. Now the DAISY is used a lot in CKD literature, and it's recommended again as a measure of physical function. In the UK, it's endorsed by the British Renal Society, and again is recommended by QQIP, which is the Kidney Quality Improvement Partnership. And there is actually some preliminary data with this question as well from London, that shows that a DAISY score of above 23 is associated with a better survival after 3 years. So again, this potentially has the ability to predict long-term health in patients. And what's important as well in terms of renal rehabilitation is that this is actually sensitive to detect changes following a rehab intervention. So again, this is a London CKD group, and they did a 12-month renal rehabilitation program. So this is that in-centre program I was talking about before. And you can see here that the DAISY increases over 12 months. So it's actually sensitive enough to pick up changes. So they're just two subjective measures. There are a lot of others. The Barthel index as well is often used in CKD. So I'm just going to talk to you now about objective measures. So objective measures quantifies what a patient is actually able to do. So rather than what they think they can do, it's actually measuring what they can do. And this often uses variables such as speed, force, time as a variable, and often uses continuous data. And so this means it gives us a much more discriminative ability. So rather than yes, no, or a Likert scale between 1 to 5, this gives us much more range, which is important, as I'll come on to later. And again, objective measures are recommended by KDOQI to measure physical function in CKD. So they're really important. And as I said before, objective measures can be split into two types. Laboratory tests, as we call them. So these are often very complex. They're highly accurate, but often very impractical in a renal rehab situation. They can be costly and often require trained personnel. And these, as I said before, are measuring the impairment at a structure level. Now, often what we do, we use field tests, if you like, as a surrogate measure of these. So these are more practical, they use minimal equipment, they're very easy to do, very low cost, and these reflect potentially limitations that are more applicable to patients and what's actually more interesting, so activities of daily living. So an example, for example, if we've got cardiopulmonary exercise testing, a good surrogate measure would be a shuttle walk. And if we want to measure strength, so an isokinetic measure of strength, we could potentially use a sit-to-stand test as a surrogate marker. So I'm going to talk about 3 objective measures. Okay, there are a lot more, but I'm just going to focus on 3. Again, these aren't necessarily the best ones, but these are common ones that are used. So I'm going to start with a cardiopulmonary exercise test. So most of you will know what this is or have seen one of these before. These provide a pretty thorough evaluation of somebody's pulmonary, so their lungs, the heart, the neurophysiological and the muscle system, and tell us how good a person is at getting oxygen into the lungs and to the muscles. However, whilst being very accurate, you can see that it's very complicated. So usually requires some form of oxygen uptake, mask, an ECG. Usually have a nurse to conduct that, a physiologist, potentially a doctor there to supervise it. They often have their blood pressure and their pulse tested at the same time. So it's quite complex, but it does give us a very good measure of oxygen uptake and is very good at measuring somebody's exercise tolerance. And in dialysis patients, so this is 175 patients with on dialysis, you can see here that a value of less than 17.5 millilitres per minute per kilo, so this is oxygen uptake. Less than that is significantly increased with worse mortality, and this was after 2 years. So this is the group with a low VO2 here. So again, it's a very good predictor of long-term outcome. So the field test version of this, if you like, is there are many of these, such as the 6-minute walk, which you may have heard of, but in Leicester particularly we do the incremental shuttle walk test. So this is a 12-stage progressive test. So patients walk around cones 12 metres apart, and it's a bit like the bleep test. The bleeps get quicker and quicker and quicker, okay, and the patient just has to keep up. This is validated as a measure of VO2 peak, okay, in kidney disease, as well as other groups, so COPD, cardiac patients, and in our opinion has advantages over the 6-minute walk, which is the other common one. So firstly, it relies less on patient motivation. So it's governed by the beeps. So patients have to keep up with the beeps. It's not they don't have to self-regulate their walking speed. Secondly, it actually gives you a maximum value. So it tells you how hard a patient can work. And this is really good for then setting exercise intensity. If we want to find what 80% of somebody's max is, we can do this test to find out. And you don't get that with a 6-minute walk test. And it can also be done in a much shorter area, so just 10-metre areas required. So we like this test in Leicester anyway. We also, very preliminary, I haven't put this on there, we do have some data as well to show that this is also related to mortality, which hopefully will be coming out in the next year. So again, potentially has a predictive value. And then lastly, in terms of the objective tests, is the short physical performance battery. And I'm sure most of you have probably heard of this or seen this before. So this is a well-established tool to test lower body function. And importantly, it gives you different aspects of lower function. It doesn't give you strength, it gives you other different bits and pieces. So this is based on 3 tasks: balance, walking speed, and a chair test. And you get a score between 0 and 12. So 0 being the worst, 12 being the best. And this is used extensively in renal rehabilitation research, as well as other populations. So the elderly, diabetes, cardiac patients. There's lots of data to show it's associated with mortality, hospitalization. So again, has very good predictive value. Now, why we like this test is, like I said, it gives you different aspects of somebody's function that can be done quite easily. The first one is balance, so all patients have got to do is stand in these 3 positions for 10 seconds. So this one's usually quite easy, this one is quite difficult. And we know that poor balance is a problem in CKD, and particularly it's associated with increased fracture and fall risk. So testing balance is really important and often overlooked. The second bit is gait speed, so how quickly somebody can walk. So gait speed, again, is a recommended measure of physical function in CKD, and there's lots of data now to show that it's a strong predictor of mortality. So this study from the USA by Bob Ross and Raven's group showed that for every 0.1 millisecond decrement in gait speed was actually associated with a 26% higher risk of death after 3 years. It's a very powerful predictor of future health. And simply all patients got to do is walk for 4 meters, and that's it. And lastly is a chair stand test. So there are lots of different chair stands tests. There's a sit to stand 30, a 60, a 10. But this one uses the 5 repetitions, so it's how many times a patient can stand up, sit back down 5 times. And this is used as a marker of lower limb strength or power, although this has been questioned slightly. Again, this is recommended as a measure of function in CKD. So you can see that this test offers you 3 different tests that measure different aspects of a function. Okay, so the last 10 minutes, if you like, are my 6 important considerations, if you like. So this is what you should look at when you're interpreting or using physical function. So the first is the reliability of a test. So this is how repeatable is a test and how free is it of measurement errors. So this is really important in knowing, because if an assessment isn't reliable, then we don't know whether something hasn't occurred by chance. So there are 2 types of reliability. Relative reliability. So this is if I do a test on day 1 and then I repeat it a couple of days later, how different are they? And this is measured using something called the intra-class correlation coefficient. The second type of reliability is absolute reliability. And this concerns an individual variation. So how different would I do it if I did it a couple of days later? So what's the error in each person? And this is measured by the standard error of measurement. So as an example, how reliable is the incremental shuttle walk test? So this was a paper that we've just recently published in CKD. So we got patients to do repeated tests, and you can see that from test 1 to test 2, there is very little difference in this. So 9 meters, and that's it. So the ICC value, the closer to 1, the better. So this is very, very good, and there was no significant difference. So the incremental shuttle walk test is a reliable measure. So it's got good retest reliability. The second consideration is validity. So the validity of a test is, does it claim what it claims to measure? So is it testing what I want it to measure? Again, there are 2 types of validity: content validity and criterion validity. So the content validity essentially is measuring, is it testing what I want it to test? And does it test the mechanisms behind it? The criterion is, does it relate to other measures? So does the incremental walk relate to the 6-minute walk? And how well is it good at predicting outcome? So these are all important measures of validity, and depending on what you're using the test for, would require different forms. So if you want it to predict somebody's mortality, then you want it with a good predictive validity, for example. Again, an example. So is the incremental shuttle walk test a valid measure of somebody's fitness? So this would be a measure of content validity. Is it testing what I want it to test? Again, this is the same paper from our group. This is the incremental shuttle walk here, and VO2 peak measured using cardiopulmonary exercise test. So this is gold standard, and this is their walk. And you can see here that there's a nice linear relationship between the 2. A pretty good R value. So the incremental shuttle walk is a valid measure of aerobic capacity. And hopefully in the next 6 months or so, we're going to publish the equation so you can predict their VO2 peak based on how far they walk during this test. Third consideration are called floor and ceiling effects. So some of you will know what these are. So a ceiling effect is when people score the maximum score of an outcome, and a floor effect is the opposite. It's when people score the lowest score of an outcome. Now these often occur in questionnaire assessments, and you can tell whether you've got a floor or a ceiling effect when more than 15% of your sample have either got the top score or the bottom score. Now this is really important. So you want an assessment without these in them, because it compromises your statistical analysis, which requires, so if you're doing an ANOVA, this requires analysis of variance, but if you've got these in your assessment, then you have no variance. but also they reduce your content validity, as I'll show you. So this is the DAISY, which I was talking about before. Whilst a very good measure, the DAISY is unfortunately very vulnerable to ceiling effects, especially in high functioning patients. You do get this in CKD because we've got some data, but this is from cardiovascular disease patients, but you do see it again in CKD. So you can see here that these patients all along here have scored the top score in the DAISY, okay? And this is due to that yes-no nature. So you can see that in these patients here, it's actually going to be a very poor measure of physical function, because this guy here, for example, could be scoring, if this went on, could be scoring much, much higher. So in CKD, there's been some evidence to show that the DAISY is only reliable in those with low EGFR, so those with lower renal function. And I hazard a guess that that's probably because they've got lower functional capacity. So this is really important because when you're picking an assessment method for your patients, you need to be aware of how highly functioning your group is. If you've got a highly functioning patient group, then the DAISY, for example, isn't probably the best test to use, and you might need something with a bit more discriminatory value. Consideration number 4 is to do with p-values. So most of you will probably come across these before. So when we're looking at an assessment, what's really important is that we understand whether the change that's happened is actually real. How do we know that if somebody improves, whether they've actually improved? Now, in research, unfortunately, a lot of whether somebody's improved or not is down to the p-value and the analysis. Now, p-value only tells us whether that change has not occurred by chance. Now, thankfully, in research, we're starting to use more effect sizes and confidence intervals, and these are really helpful in us interpreting the data, but there are better ways. So, what is a true change and how do we calculate it? So firstly, we need to understand that a change following a renal rehabilitation program is not due to error or variation, okay? And this can happen at a patient level, or it could be to do with the test. And this is linked a lot to the reliability. So if you've got a reliable test, these should be reduced. Now, a more clinically useful means of interpreting this is something called the minimal detectable change, which we've been doing a lot of research on in Leicester. And this is defined as the smallest amount of reliable change in a measurement necessary to conclude that the difference is not attributable to error. So I'll just kind of rephrase it. So essentially, this is the smallest number or the smallest change that has to occur that you can be happy that it's not just due to natural variation or natural error. So we've just published this earlier this year. So what we've done is actually we've got the minimal detectable change values for a lot of functional measures in CKD. So there is also a paper from a Spanish group which have very similar measures in dialysis patients. So depending on what group you work with and the tests you use, these two papers might be of use. So in this paper, we looked at the minimal detectable change values in individuals and groups. So these are the tests we use. So we use the incremental shuttle walk test, which I've explained. The sit-to-stand 5, which I've explained. The sit-to-stand 60, so this is how many times patients can stand up and sit back down in 60 seconds. Estimated 1 repetition, so this is a strength measure in kilos. And then VO2 peak, so that's from cardiopulmonary tests. So you can ignore this column here because this is the standard of error. It's these two here that are important. So the minimal detectable change at an individual level is the minimum number that an individual will need to improve by for you to be happy that it's not just due to variation, motivation, error. So if you're working one-on-one with a patient in a rehab situation, in terms of the incremental shuttle walk test, they need to have walked more than 20 meters in order for you to be happy that that's a true change. In the sit stand 5, it's 7.5. They need to have improved by 7.5 seconds for you to be happy that it's not due to error. And in VO2 peak, they need to improve by almost 3 milliliters for you to know that that's not just due to error in the test. When you're looking at groups, so maybe when you're reading papers or reviewing literature, these are a little bit smaller, and that's just due to the numbers. So the incremental shuttle walk is 3 meters, and the VO2 peak is 0.5. So these are the true changes. So these occur when values exceed these numbers here. So these are really useful to know. And then a quote from Jean Glass says, "Statistical significance is the least interesting thing about the results. You should describe the results in terms of magnitude, not just does a treatment affect people, but how much does it affect them." And this comes on to my last point. So if our intervention is a true change, so it's not due to error, so we're happy that it's a true change, and it's significant, we've got a significant p-value, that's all good, but actually does that make any difference to a patient? So if a patient improves by 20 meters on a walking test, yes, it's true, yes, it's significant, but does that make any difference to their health or to them? And it's really important that we actually recognise or begin to recognise what changes are actually beneficial to a patient. Now this actually has a term, which some of you may have come across, called the minimal clinically important difference. Okay? And this is defined as the smallest change or difference in an outcome that is perceived as beneficial or important by the patient. This has been around since the 70s, but it's only recently in the last kind of 10 years starting to come more and more into rehabilitation. In renal rehabilitation, I don't know any studies apart from the one that hopefully we're about to publish anyway. So there are a couple of ways that you can assess whether it's important. Now one method is something called the anchor-based method. So essentially with this, you have a questionnaire, or you can ask the patient of self-reported quality of life. So in our case, we took the SF-36, okay? And then what you do, you map their changes in function to their perceived changes in health. So we did this following a renal rehabilitation program. So it was a 12-week program, 3 times a week, mixture of both aerobic and strength training. And these are what we found. So again, very similar test before. So I'm going to take the incremental shuttle walk test as an example. So we found that in order for a patient to actually feel a benefit, they need to have improved by at least 45 meters in this test. So if you're looking at a paper, or you're looking at somebody's change, we've shown that roughly they need to improve by this much in order for they to actually feel the benefit from it. And this actually is really close, which we were quite happy with, in both pulmonary and cardiac patients, which are 48 and 46. So this is quite consistent, this number. In terms of sit stand 60, they need to improve by 5 and they will feel a benefit. And in the sit stand 5, they need to reduce their time by 4.2 seconds, and that's when they start to feel the benefit on their health. And in terms of VO2 peak, this is 1.5 milliliters per kilogram. So again, quite close to some studies in the elderly. So this is currently under review, so hopefully it will in the next year it should come out. But yeah, so it's really important that when you're analysing or interpreting changes, that you actually are aware or thinking about whether they are making any difference to the patient. So my last slide is kind of a checklist, if you like. So when you're looking at test or assessing test, you need to be aware, is the test valid? Okay, is it testing what I want it to test? Is it reliable? Are there any ceiling and floor effects that potentially may be impacting it? What's a true change? So how much error is in the test? And if I get a change, is it actually meaningful to the patient? Thank you very much.